Okay, so before we start, a short introduction. Some of you might be knowing me, some of you might not be knowing me. So I'm Dr. Falak. I'm basically from Pakistan, Karachi, Pakistan, and I'm FCPS Ops and Gynae and MRCOG. And today we are going to have a session on basically this is about NICE guideline on miscarriage and ectopic pregnancy. The reason I chose this topic is at the level of IMM, you are expected to know everything about miscarriage and ectopic pregnancy since they are so common and we do see these type of cases in our everyday lives. And if you get an idea, it's very easy. Trust me, it's very easy. And besides that, in the end, I would like to have a question and answer session with you. If you guys have any queries, you are more than welcome. So shall we start? Guys, can you hear me? Okay, let's begin.
Yes, we can. Yes, we can.
Okay, let's
Yeah.
begin. So, first and foremost, we must know how to diagnose a viable intrauterine pregnancy and an ectopic pregnancy, and only then we would be able to manage it. So, starting with ideally we should go for a transvaginal ultrasound scan rather than a transabdominal scan, which we usually most of the people go for a transabdominal scan. We must know that TVS is ideal to identify the location and viability of a pregnancy. A transabdominal ultrasound scan can be considered if the uterus is enlarged or if other pelvic pathology is suspected, such as fibroid or ovarian cyst. Whenever we are performing a scan, the first thing we have to look for is a fetal heartbeat. If there is no fetal heartbeat, but we do have a fetal pole, then we measure the crown rump length. If the fetal pole is not visible, only then we measure the mean gestational sac diameter. So this is the basis of how we diagnose it. Coming forward, so we must know what at what gestational age we are expected to get a fetal heartbeat and what to do if we don't get one. So if we are doing a TVS, there are some cutoff values that we must memorize. We have to do it because we don't have a choice about it. So whenever we are doing a transvaginal ultrasound scan, if you see a fetal pole, as I told you, we measure the crown rump length. If it is more than 7 millimeters, but a fetal heartbeat is not visible, we have two options. Either we seek a second opinion immediately or we repeat a transvaginal scan 7 days later. And if we get the same findings in two scans, which means no fetal heartbeat, we diagnose it as a missed miscarriage. We cannot diagnose it on one scan. If the CRL is less than 7 millimeters on a transvaginal scan, we repeat a scan 7 days later. So this is how we diagnose miscarriage on the basis of CRL. If there is no fetal pole, obviously, then we are going to go for mean gestational sac diameter. The cutoff value would be 25 millimeters. If a mean gestational sac diameter is more than 25 millimeters and no fetal heartbeat is visible, again, we follow the same rule as we were doing for the CRL. We seek a second opinion or we repeat a transvaginal scan 7 days later. So this is on transvaginal scan. Now coming to transabdominal scan, if we are doing a transabdominal scan and there is no visible fetal heartbeat, uh, either we are measuring CRL or we are measuring mean gestational sac diameter, what we do is we repeat the scan 14 days later, which makes it 2 weeks. So this is the basis how we diagnose a missed miscarriage. Any questions so far, guys? Am I clear so far?
Yeah.
Okay, so moving forward, uh, uh, so coming to pregnancy of unknown location, anybody of you would like to tell me what pregnancy of unknown location could be? Basically, pregnancy of unknown location is when the beta HCG is positive, but there is no visible gestational sac, intrauterine or extrauterine. We call it pregnancy of unknown location. In such cases, what we do is we measure the beta HCG levels, that is two levels 48 hours apart, and we are expected to see a rise or a fall which will help us make a management plan for the patient. So if the rise in beta HCG is more than 63%, it is highly likely that it is an intrauterine pregnancy. What we have to do is we just reassure the patient and we advise a transvaginal scan for viability 7 to 14 days later. This is one situation. The other situation is if the levels fall more than 50%, it is likely to be a failing pregnancy. You advise the patient to take a urine pregnancy test 14 days later, and no further action is needed if it is negative. So these are two possibilities. The third possibility is there is a rise, but it is less than 63%, or there is a fall, but it is less than 50%, in which case we need to refer for a review within 24 hours. There is a high possibility that it could be an abnormal pregnancy, maybe an ectopic pregnancy. So the three possibilities that we have for pregnancy of unknown location are either it could be a viable intrauterine pregnancy, either it could be a complete miscarriage, or it could be an abnormal pregnancy like an ectopic. So coming forward, this was how we manage pregnancy of unknown location. Coming forward, as we discussed miscarriage, we had discussed how to diagnose a miscarriage, a missed miscarriage. So the management options, basically we have three management options: expectant management, medical management, and surgical management. Expectant management is the first line management strategy, and we what we basically advise to the patient is to wait for 7 to 14 days and let the nature take its course. But for the patients who are at increased risk of bleeding, for suppose the patients who have coagulopathies, or if there is advanced gestational age, or if the patient has previous bad experiences like hemorrhage, in which cases we possibly consider medical or surgical management rather than expected. But otherwise, for a normal patient, expectant is the first line. It is 50% successful. We advise the patients to perform a urine pregnancy test 3 weeks later to confirm that it has been completely expelled. Coming forward, so the next management option is medical management. There is a confusion. Many people confuse it that mifepristone is supposed to be used, but no, mifepristone is not supposed to be used in cases of miscarriage. Vaginal misoprostol is used. Oral route can be a suitable alternative. The dosage for miscarriage, the dosage of misoprostol for miscarriages, for missed miscarriages, we go for 800 micrograms. For incomplete miscarriage, we go for 600 micrograms. We advise the patient to come back for a review 24 hours later. And because misoprostol can cause vomiting and pain, so we offer pain relief and antiemetics along with misoprostol. And also, again, similar to the expectant management, we advise the patient to take a urine pregnancy test 3 weeks later. And this medical management is successful in 85% of cases. Any questions so far, guys? We can move forward or no?
Yeah, we can move forward.
Okay. So the next is surgical management. So in the surgical management, it could be an MVA in the outpatient setting, or it could be a surgical management under general anesthesia in the theater. Both options are suitable depending on the patient preference. The success rate is 95%. This is very simple. The management of miscarriage is very simple. It's just that we should know this at the level of IMM. It is must for a candidate who is sitting for IMM. We are done with miscarriage. Coming to tubal ectopic pregnancy, again, we have three management options: expectant management, medical management, surgical management. There are few criteria that should be met in order to decide on what management option would be most suitable. Before we discuss the management, a short discussion about how to diagnose ectopic pregnancy. Whenever you have a patient who is in reproductive age with lower abdominal pain or symptoms of UTI or even GI symptoms, must think about ectopic pregnancy, must offer her a pregnancy test, keep a high level of suspicion when you are examining or when you are reviewing a women of reproductive age. The presentation of ectopic pregnancy can be highly variable. Even sometimes it can mimic UTIs or GI disturbances. It can present with even bilateral tenderness rather than unilateral. So high index of suspicion is very important. Now, coming to the management options, expectant management, the criteria are the patient should be clinically stable, the patient should be pain free, gestational sex should be less than 35 millimeters in size. No fetal heartbeat should be there. Serum beta HCG should be less than 1000, but we can consider it at less than 1500 as well. And the patient should be able to follow up. Follow up is very important. If a patient is not able to follow up, we cannot advise her on an expectant management because otherwise she may end up in having a ruptured ectopic pregnancy. Whenever you go for expectant management, what you do is you repeat the beta HCG levels on day 2, day 4, day 7, and you expect a fall in HCG levels by more than 15%. And then you repeat beta HCG levels weekly till it's negative. This is basically the expectant management. The next treatment option is medical management. Medical management is systemic methotrexate. Again, we have some criteria for medical management. The patient needs, it is more or less similar to expected management. The only difference is about the beta HCG levels. So the patient should be stable, the patient should be symptom free, the patient should be able to return for a follow up. There should be no fetal cardiac activity. Gestational sex should be less than 35 millimeters. Beta HCG should preferably be less than 1500, but it can be considered at less than 5000 as well if all other criteria are met. Whenever we go for methotrexate, we must check full blood count, liver function test, and renal function test. The reason is methotrexate can cause hepatotoxicity, nephrotoxicity, and even sometimes it can cause thrombocytopenia. So we must check these labs before we give a patient methotrexate. Again, we have to monitor serum beta HCG levels on day 4 and day 7, and then weekly until they are negative. Again, we expect to have a fall of at least 15% between day 4 and day 7. The third option is surgical management. Surgical management should ideally be laparoscopy if it is available in the setup. Again, we need some criteria. If the patient is clinically unstable, obviously we cannot manage her expectantly or medically, so we go for surgical management. If the patient has severe pain, if the gestational sec is more than 35 millimeters, or if fetal cardiac activity is positive, and if beta HCG is more than 5000 international units per liter, then the suitable option would be surgical management. Within surgical management, we again have two options: self-injectomy and self-angiotomy. Self-injectomy is basically cutting the tubes and removing the part of it, and self-angiotomy is giving a small cut, removing the pregnancy, not removing the tube. So whenever the contralateral tube is healthy, self-injectomy is ideal. But if the contralateral tube is unhealthy, we go for a self-angiotomy. The reason is we want to conserve the patient's tubes, but we must tell the patient that 1 out of 5 women may need further treatment in the form of methotrexate or self-injectomy. So this is basically medical management. Follow-up criteria is very important. If we have gone for a self-injectomy, we advise the patient to do a urine pregnancy test 3 weeks later to make sure that there is no ongoing pregnancy or there is no persistent trophoblastic tissue. If we have gone for a self-angiotomy, we advise the patient to get serum beta HCG levels checked weekly until they are negative. Do not forget giving injection NTD to all patients who have surgical management of miscarriage or an ectopic pregnancy. This is very important. We give 250 international units intramuscular within 72 hours, preferably, or if not within 72 hours, then at least within 10 days. So, guys, are we clear so far? If anybody of you can unmute yourself and let me know. Any questions or any doubts?
Yeah, just a clarification regarding the
Yeah.
NTD.
Yeah.
It's obviously for resource negative patients, right?
Yeah, of course, obviously, for rhesus negative, non-sensitized patients. For suppose if a patient is already sensitized, obviously giving NTD doesn't make a sense. So yes, it was a great question. Thank you for that. Um, any other doubts? Any one of you, or you need any clarification? Okay, so we have some activity. Now, if anybody of you would like to volunteer for a few questions that I have made for you, any one of you would like to try? Anyone?
Yeah.
So would you like to try? Give it a try.
Yeah, sure.
So should I read it for you? The question? I hope you'll enjoy doing it. It's just a brainstorming. So, a 24-year-old Gravida 2 para 0 plus 1 presented to the ER with complaint of mild lower abdominal pain and a brownish vaginal discharge. Her LMP was 6 weeks back and she has a positive urine pregnancy test. Her ultrasound scan has been done and shows a positive fetal cardiac activity. Her serum beta HCG is 1093 international units per liter. She has a history of right sided salpingectomy due to a ruptured ectopic pregnancy 2 years back. What would be the best management option for her? Would anybody of you like to volunteer and answer this question? Any thoughts or any ideas?
Expectant management.
Um, Actually, expected management is not suitable here. The reason is there is positive fetal cardiac activity. So whenever, as we discussed, whenever there is cardiac activity, we go for surgical management. The second thing is there is a history of salpingectomy in the contralateral tube. So salpingectomy won't be a suitable option. So the best option is laparoscopic salpingectomy in this case because we want to conserve the other tube and we have to go for a surgical management irrespective of anything because she has a positive fetal cardiac activity. So great. Thank you so much for your participation. We have another question and let's have a discussion on it. I hope it's useful for you. So
I'm sorry, regarding the
yeah, yeah.
first one, sorry.
Yes, yes, yes. Yes,
It
sure.
wasn't
And
specified where the pregnancy is.
it is an ultrasound scan has okay. Basically, it is a case of ectopic pregnancy. She has presented with mild lower abdominal pain and brownish vaginal discharge. LMP was 6 weeks back. She has a positive urine pregnancy test. Ultrasound scan shows. I'm sorry, I should have mentioned that she has a left-sided tubal ectopic, and there is a positive fetal cardiac activity. You have picked it very right. So this is another ectopic, and the reason we are going for salpingotomy is that she has salpingectomy previously, and also she has a positive fetal cardiac activity. Am I clear?
Yes,
Thank
now
you.
clear
Yeah.
because not written that it is
Okay.
intrauterine unknown location.
Yes. This is basically an ectopic pregnancy of the left side. I I should have mentioned it obviously, but I hope you it's clear to you guys, or you guys want me to repeat it for you. Samina, would you
It's
like to
clear
Clear,
now.
repeat
clear.
it? Okay, great. So anybody of you would like to try the second question? I can read it for you. Would you like to take it, Samina? I'll read it for you guys, and if anybody of you can participate, I'll be very thankful for that. A 36 years old primary gravida presents to the ER with a complaint of lower abdominal pain and bleeding per vagina. Her LMP was 7 weeks back. Her transvaginal ultrasound scan shows a confirmed diagnosis of miscarriage. CRL 8 millimeters, no fetal cardiac activity confirmed by 2 sonographers. She is a known case of von Willebrand's disease and has history of heavy menstrual bleeding. What would be the most suitable treatment option for her? Expectant management, medical management with mifepristone followed by misoprostol, medical management with misoprostol only, or surgical management? What do you guys think?
B.
As we
I think
discussed,
surgical.
yes. As we discussed, the women who are at a higher risk of bleeding, we prefer surgical management rather than medical or expectant management. The reason they are more likely to bleed heavily. So in those cases, we usually prefer surgical management. Otherwise, expectant management would have been first line. But the only reason here why we chose surgical management is because she has history of HMB and she also has a bleeding disorder. Am I clear so far, guys? Any questions or any doubts?
No, clear.
Shall we move forward? So anybody of you would like to take the question number 3? And would you guys read it for me as well? Shall I read it? Okay. Would you like to do, Samina? Or Faria, anybody
Because
of you?
sound is not clear. It is too much interruption.
Is it okay now?
Too
Is
much
it better?
interruption in the sound.
Okay.
But
Is it better? Is it for everyone? Everybody is having a problem with the voice?
no, the same.
Is it better now, guys?
Yes.
How is it? Is it better? Anybody let me know if it is clear now?
I think the sound is okay.
It's okay? Great. So a 16 years old teenager presents to the outpatient clinic with a positive pregnancy test. TVS was done and shows empty uterine cavity with normal tubes and ovaries. This is an unwanted pregnancy and she wants a termination of pregnancy today. What would be your advice? So basically, this is a pregnancy of unknown location. She has a positive pregnancy test. The TVS shows normal tubes, ovaries, empty uterine cavity. So what would you advise her? What would you like? Would anybody of you like to volunteer this question and let me know about what are your thoughts?
I think B.
Yes, it's serum beta HCG levels twice 48 hours apart because this is a pregnancy of unknown location. So as we discussed, the management for pregnancy of unknown location is we check serum beta HCG levels 48 hours apart. And would anybody of you tell me about what ranges we take? What is the cutoff level to decide on whether it is viable intrauterine pregnancy or failing pregnancy?
63% rise for a
Yes.
viable pregnancy, and
Exactly.
if there's a fall of 50% or less than 50%
Great.
non-viable. Yeah.
Yes, it's a failing pregnancy. Great, great, great. You're absolutely right. So the correct answer is B. Thank you so much for your participation. And there is another question. I would be very, this is the last one. Would anybody of you like to do it? Mm-hmm. Shall I read it for you guys? A 28-year-old primary gravida presents to the outpatient clinic with complaint of mild lower abdominal pain. Her ultrasound scan was done and shows a donut sign, a mass in the right ovary, no free fluid in pouch of Douglas. A diagnosis of ovarian ectopic has been made. Her serum beta HCG level is 1100 international units per liter. What would be the most suitable treatment option for her? So this is basically ovarian ectopic. She has mild lower abdominal pain, no free fluid. Her serum beta HCG is 1100. What do you guys think?
Laparoscopy resection of ovarian ectopic.
Uh, because the patient has mild symptoms and there is no free fluid and her serum beta HCG is also 1100. So this is a suitable candidate for systemic methotrexate. If the patient was having severe symptoms or she was clinically unstable or if her beta HCG was very high, like more than 5000, so preferably we would have gone for surgical management. But in this case, injection methotrexate would be a suitable option, keeping in mind the symptoms that the patient has and also the beta HCG levels. What do you think, Samina?
What, ma'am?
basically this patient falls under the criteria of medical management because she has mild pain. She doesn't have severe pain. Her serum beta hcg is 1100. There is no free fluid in pouch of Douglas, which means that the ectopic has not ruptured yet, so we can consider intramuscular injection methotrexate for her.
Because sound too much interruption. I cannot understand the question. Too much interruption.
I'm sorry guys if it is from my side. Is it from my side? Is it unclear for everyone?
Might be from my side, but very
Oh,
interruption in the
I'm so sorry, Samina, for that. No problem.
I'm
Yeah, this recording would be available on the Facebook as well. You can go through it. I'm sorry if the interruption is from my side. I usually my internet works well. Uh, you can even drop me a message if you have any queries. So would any of you any of you has any queries, or would you like to have any particular, would you like to know any particular thing about exam or anything? Please, I will be more than happy to answer your queries. Anyone?
yeah, I'm trying to join from other.
Okay, I'll wait for you.
Recording in progress.
Yes, ma'am.
Is it clear now?
Now it is clear.
Would you like me to repeat the last question?
Yeah.
So basically, this is a diagnosis of ovarian ectopic, and the patient has mild pain. She doesn't have severe pain. There is no free fluid in pouch of Douglas, which means that the ectopic has not ruptured yet. And the serum beta hcg is also 1100. So she is a suitable candidate for injection methotrexate because all the criteria of methotrexate are being met over here.
Yes. Because
Is it clear?
by mistake, I was thinking it is 11,000. That's why I answered this.
Okay. So do you remember
Thank you.
the cutoff? Do you remember the cutoff level for surgical management that we just discussed?
Yes. Yeah.
How much was that? It was 5,000.
5,000. Yeah.
If
If
it is more
methotrexate
than
less
5,000,
than 5,000, less than 5,000, we can consider for methotrexate.
exactly, we can consider for methotrexate if all other criteria are met. Any questions or any doubts for any one of you, or if you would like to ask anything about IMM, any particular thing, I will be very happy with that. Any questions? Nobody has a question? Is it clear to all of you?
This mifepristone and this misoprostol, doctor, you can tell us the difference when we have to give, when we have to not give, because I joined very late. I came from
No
the duty.
problem. No problem.
Yeah.
Basically, mifepristone is given for termination of pregnancy, which means abortion. It is not given for miscarriage. For miscarriage, you simply give misoprostol, and the dose is for missed miscarriage, it is 800 micrograms. For incomplete miscarriage, it is 600 micrograms. Preferably, you give vaginally. Oral can be an alternative. If the patient wants oral, you can give oral, but it has some side effects. It can cause diarrhea, vomiting, pain. So along with misoprostol, you always give pain relief. You also give antiemetics, and you advise the patient to take a urine pregnancy test 3 weeks later to make sure that the management has been successful. Mifepristone is not required in miscarriage. It is basically used for abortions or terminations.
Thank you, ma'am. Thank you.
Would you like me to repeat anything, Samina, for you, since you joined
No,
late?
very nice. Because I attend from this medical management, this mifepristone and this misoprostol.
Okay. This is a very it is a very easy topic if you understand it. And at the level of IMM, you are expected to know the management of miscarriage, you are expected to know the management of ectopic pregnancy, and both of these are very important because I'm sure you must be seeing these sort of cases in your everyday life. So this is very easy if you just remember a few key things about the criteria for medical and surgical, and expectant management, how to follow the patient, what are the criteria, then it's more than enough for this topic. There's nothing much
Yeah.
about it. It's very simple if you understand the entire thing.
Yes, it is little tricky, but very nice. If you
Yeah.
first you will understand, you will manage very well.
This nice guideline is an excellent guideline. It is not a very lengthy guideline. If you go through it, you would be able to at least solve all the questions in your IMM, in your FCPS part 2, even in your long case and extended talks. It will be very helpful. This is a very good guideline. I would really advise you to go through it yourself at home.
Yeah,
Anything
because
that you
we
want?
have very
Yeah.
interesting, very interesting case in our ward. I'm actually
Okay.
working in Riyadh. So this case
Okay.
is not still not diagnosed. It is unknown location or it is complete abortion because her beta HCG is coming high. But
Okay.
this on ultrasound, transvaginal ultrasound, there is nothing. MRI is clear.
How much?
So
How much
under
is the?
still she is
How much is the
the
beta
last one
HCG
today is
level?
10,000. 10,000 today,
10,000.
but there is
Uh,
not appearing. Yeah,
Usually, we expect to see a pregnancy at 10,000 beta HCG.
yeah, yeah.
It can be a molar pregnancy, or it can be a, ovarian tumor, beta HCG producing ovarian tumor, that is ovarian choriocarcinoma. It can be that. If does she have any ovarian
Yeah,
cyst or anything like that? That's an interesting case, I
because
must
the
say.
problem she passed, yeah, she passed some tissue, but nothing, anything. So
Okay.
under follow up, she is, yeah, yeah,
Okay. She passed some tissue. Okay. So molar
tissue,
cannot
but
be
the beta
excluded.
HCG, yeah, she passed the tissue, but beta HCG is coming high. It start from
Okay.
8,400, then 8,900. The last one is 10,000. So
She
until it
can
is in
be
follow up.
she can be a case of molar pregnancy. Sometimes molar pregnancy develops after a miscarriage as well. So she needs a clear follow-up until a cause
Yeah,
is
yeah.
found. Thank
Before
you
we
so
are
much.
thinking that maybe it will be abdominal, but the things, so
It
MRI
isn't.
was clear.
Okay. Okay. Thank you so
Thank you,
much,
ma'am. Very
Samina, for
nice.
your input and for sharing this excellent case with me. Thank you so much.
Yeah,
Anything that any of you would like to ask?
very
If any
nice
of
lecture.
you, if you, any one of you have a particular topic that you want to discuss, any guideline, we can arrange another session for you guys. Okay, so if there are no questions, we can say a goodbye to each other, and I would be more than happy if you guys have any questions. You can drop me a message on the Facebook, or even on my personal number. You can drop me a message. I will be more than happy to address your queries. And thank you so much for participating. I am overwhelmed. Thank you so much.
Thank you, ma'am. Thank you. Very nice lecture.
Thank you. Thank you.
Thank you, ma'am.
Thank you.